All right, a very good evening to all of you. A very good evening to all of you. Am I audible? Yes, everyone, am I audible? How is the audio visual? A very good evening to all of you. How is the audio visual? This is Dr. Kashish Grover, your PSM faculty. All right, a very good evening to all of you. Can we start? Guys, can we start? If the audio visual is perfect, can we start? If the audio visual is perfect, can we start, guys? All right, so first question, quickly, guys, first question. So this is Dr. Kashish Grover, your PSM faculty. Guys, we are discussing mini test series you must have attempted on NEETPG app, and after attempting those 15 questions, we are here to discuss those 15 questions, and I hope you guys enjoyed those 15 questions. And now let's quickly start. Question number 1, Being's model. Being's model. So this question is talking about Being's model. Guys, we have heard about various models of disease causation, and one of them is Being's model. Being's model says that these are the probable factors which are there in causing a disease. So guys, what is B in Being's model? Anyone? If you know, you are free to write in the chat box. Guys, you are free to write in the chat box. We need maximum two-way interaction. I don't want to be the only one who is participating in this interaction. I want your participation also, guys. B. So Being's model says that behavior. In Being's model, B stands for behavior. B stands for behavior. Now, in Being's model, B stands for behavior. So there are factors related to behavior which are responsible for causing certain diseases. E stands for environment. E stands for environment. There are certain factors. Which are responsible for causing the disease. Environment. N stands for immunological. N stands for immunological. Nutrition related factors, genetics related factors, social factors, spiritual factors, and service related factors. Guys, what is service related factors? What is service related factors? Like when you are not aware, when we are not getting the proper health services. So this is service related factor. Nowhere in this discussion there is religion related factor. So here the correct answer is religious factors. Here the correct answer is religious factors. Now guys, this was Being's model. This was Being's model of disease causation. This was Being's model of disease causation. Now there is another model of disease causation, Wheel's model of disease causation. Anyone? Wheel's model. V. Now this Wheel's model says that every disease is happening because of the core, and the core is genetics, and around the genetics we have environmental factors. This is Wheel's causation. Now yes, innermost is genetics. This innermost is genetics, and around that we have environmental, physical environment, our physical environment, right? Biological environment, our social environment, something like that. Now coming to next question. Guys, this question, which of the following is not correctly matched? Guys, what I am talking right now is, it is the guidelines. We are talking here about some of the guidelines which are there for the checklist of various epidemiological studies. So guys, okay, leave this question now. For right now, leave this question. Just focus on the guidelines. PRISMA. Guys, PRISMA guidelines is for meta-analysis. This is for meta-analysis. MOOS guidelines, they are also for meta-analysis, but what is the difference? The difference is the PRISMA guidelines, they are for meta-analysis of RCT, and MOOS is for meta-analysis of observational studies. Observational studies, right? So meta-analysis of observational studies. And what about consort guidelines? These guidelines are for randomized controlled trial. Randomized controlled trial. What about care guidelines? This is for case report. Care guideline is for case report. STARD is for diagnostic accuracy. This is for diagnostic accuracy. And this core Q, this is for qualitative research. This is for qualitative research. So guys, meta-analysis for PRISMA, true. Diagnostic studies for consort, this is false. Observational studies, yes. For observational studies meta-analysis, we use MOOS guidelines, and case report is for, right? So you can learn it like case report, care, case report, diagnostic accuracy, qualitative research. So this was all about guidelines. This was all about guidelines. Now, coming to next question. The next question says there is a 20-year-old student, and the student is planning to go for a tropical country which is having high prevalence of malaria, and she seeks advice on preventing malaria infection during her travel. You prescribed doxycycline. Guys, you have given doxycycline. I want quickly your reply in chat box. You are going to give doxycycline for malaria for short-term stay or long-term stay. Quickly write in the chat box. This question I'll be discussing, right? Now, which are the following level of prevention? This question is about level of prevention, but you have to type in the chat box doxycycline. You want to give it for long-term stay or short-term stay, guys. So before I tell you the correct answer, I want to tell you about the concept of primordial, primary and secondary, all of these preventions. Now, short term, very good bache. Doxycycline is given for short term. What about long term stay? What you will prescribe for long term stay? Now guys, at the end, my last slide is about all the important drugs for prevention of various important communicable diseases. Quickly, in primordial prevention, risk factor is absent. In primary prevention, the risk factor is present, but the disease is absent. Very good, bacho, very good. Mefloquine, superb. Now come back to this topic now. So in primary prevention, risk factor is there, but disease is absent. In secondary prevention, the disease is in early stage. And in tertiary, the disease is beyond early stage. So this is the main concept. This is the main concept, guys. There are very few topics in PSM which are 5-star. Those topics are vitals, right? For example, case control study, cohort study, for example, vaccines, for example, level of prevention, for example, vitamins, for example, in nutrition chapter we have food adulterants and toxins. These are 5-star topics, and we get 100% question. HDI, PQLI, these are very important, right? So we are discussing another important topic here. Now this is about the basic background. Now what is secondary prevention? Secondary prevention is screening. Secondary prevention is screening. In primary prevention, vaccines, prophylaxis, it can be pre-exposure, it can be post-exposure prophylaxis, it can be re-exposure prophylaxis, it can be pre-exposure prophylaxis. So any prophylaxis, it can be pre-exposure, post-exposure, re-exposure, it can be chemoprophylaxis or immunoprophylaxis. Any prophylaxis is primary. Any prophylaxis is primary, right? Any prophylaxis is primary. Now guys, there are some examples. Apart from prophylaxis, hand washing, wearing lead aprons in diagnostic rooms. If someone is wearing lead apron, that is example of primary prevention. In primordial prevention, we have health education. Right? And any nutrition, any supplement, any nutrition supplement is also primary. So in this case, we are giving a chemoprophylaxis, and chemoprophylaxis is primary, Sorted? Can I go ahead? Any doubt in this particular topic? Level of prevention, this is a 5-star topic. Yes, Dr. Nitya, I have given a huge list. I will share it again. Dr. Nitya, I will share it again. Right? Now guys, coming to next question. This question is very important. So here is a case. Of a 72-year-old woman. Yes, bache, yes. Pratyusha, yes. Pap smear. Yes, bache, pap smear is secondary. Even self breast examination is secondary. Even oral examination. Oral examination is now bachcho, coming to next question. A 75-year-old woman was diagnosed with carcinoma breast 2 years ago. Her condition is stable. As a part of randomized control trial, you want to put her on a new drug. You noticed that with new drug, the patient is stable. The new drug prolongs life but does not cure malignancy. Right? So in this case, what is happening? The new drug is prolonging life but is not curing the malignancy. So the examiner is asking you which of the following is correct. Guys, look here. This is the table I have given you in DVT. This is the table I have concised in DVT, right? Open your DVT notes. Very important, very concise, right? Open your DVT notes, very concise, very important. Guys, now coming to, I want to tell you one concept. Prevalence is equal to incidence multiplied by duration. If we have a very good cure, so we are giving the treatment, the patient is getting fine, absolutely fine, out of disease within 2-3 days, right? This is going to decrease prevalence. This is going to decrease prevalence. If there is a disease which is highly virulent, today the patient is getting the disease, within few days the patient is dead. For example, rabies. You will never hear about prevalence of rabies because deadly. It is very deadly. Prevalence will decrease. When we have a treatment which is prolonging life, so there is no mortality, but the disease is not curing, what will happen? The prevalence will increase. The prevalence will increase. Same is the scenario here. Look here. So here we have a drug which is prolonging life but not curing. What will happen? The incidence will remain same and the prevalence will increase. Now bachcho, coming to next question. Another very high yield topic, interpretation of relative risk. So guys, if I talk about relative risk, interpretation, retrospective cohort study, your case control study, odds ratio, these are very, very important topic. Very, very important. Now, a cohort study was done between two population. One is taking green tea and another is not taking green tea. The study was to check the association. Relative risk is given 0.8. So guys, let us quickly discuss what is relative risk? This is incidence among exposed divided by incidence among non-exposed. This is also known as risk ratio. In which study we find relative risk? If I say most commonly, it is a cohort study. Now, when relative risk is more than 1, it means incidence among exposed is more than incidence among non-exposed. Those who are exposed, they are getting more disease, right? So here we say there is a positive association. In other words, I can say the risk factor is causative. Now, if relative risk is 1, it means in both the groups, exposed or non-exposed, the disease is happening with the same rate. Those who are exposed, they are getting same. Those who are not exposed, they are also getting same. In this case, we say there is no association. When relative risk is less than 1, it means incidence among exposed is less than incidence among non-exposed. It means those who are exposed, they are protective, and those who are not exposed, they are getting the disease. So we say here negative association. But in other words, can I say the risk factor is protective? So here we have causative factor, here we have protective factor, right? So here the correct answer is green tea population has less risk of developing diabetes because risk ratio is 0.8, because it is less than 1. So those who are consuming, they are protected, right? Those who are consuming, they are protected. Now bachcho, this is one topic. I have deliberately given this topic because every time, almost every day I get one query, sir, please explain internal validity, external validity, and it is difficult to explain internal and external validity in texting. By just sending the message, it is difficult. Now, bachcho, type 1 error, type 2 error, yesterday it was covered very nicely by my friend Dr. Siddharth Mishra. So yesterday this topic was covered. Today, for today's discussion, we have epidemiology, we have your communicable diseases, we have nutrition, these chapters, right? So we both divided PSM into two halves. One half he took yesterday and one half today I am taking, right? So one student is asking again, bache, CB-NAT. Guys, see, CB-NAT is very important for starting the treatment of tuberculosis. For starting treatment of tuberculosis, CB-NAT. Okay. Now coming to, okay, let us not break the flow. Let us go with the flow. I'll take your doubts. No worries, bacho, I will take your doubts. Now it is time to listen a story. And I'm here to tell you one story. The story is, you have 1 lakh population. Okay, guys, listen the story. Right? So we have, okay, guys, for now, please listen this story. Let us consolidate this topic. Then we will go to our next query or the other topics, right? Now, but you listen the story. I have 1 lakh. Okay, suppose I want to do a study. Suppose I want to do a study where I want to test a new drug for hypertension. So I want to test a new drug for hypertension. Step 1 is to involve all the patients who have hypertension. We have 1 lakh people who have hypertension, right? I cannot do study on 1 lakh. I cannot do study on these 1 lakh people. I need only and only 1,000 people, because study involves money, it involves manpower. I cannot do study on 1 lakh people. So I will choose only 1,000. I will choose only 1,000 from 1 lakh, right? How I need to choose them? I have to choose them randomly so that everyone gets the chance. This is random sampling. Now I have 1,000 people. I need to divide them. I want to divide them in two groups. Group A will receive the new drug. Group B receive the placebo, right? Now these 1,000 people, what I can do? These 1,000 people, I can just include all the young patient here, and all the old patient here. Now what will happen? Young people, they will show better response, and I will say my drug is better. No, that should not happen. Everyone should get the chance to be divided in, to be allocated in both the groups. For this purpose, we need randomization. What is random sampling? Selecting study subjects. Random sampling. Now dividing these study subjects into groups, or you can say randomization is the process of group allocation. Now guys, just think for a moment. If I am not doing random sampling, I am including all the young patients in my study. and my study results showed the new drug is better. Now, can I apply this result to my whole population? Whole population is a mixture of old and young, but I did something wrong here. I included all the young people. This is known as external validity. This is known as external validity, when I can apply the study to the whole population. Now, what is internal validity? So, external validity is affected by, yes guys, external validity is affected by random sampling. And now coming to randomization. This randomization is the process of dividing them in two groups. If they both are comparable, this is internal validity. Now, understood? This external validity is also known as generalizability, when I can generalize my results to the whole population, right? So in short, external validity is also known as generalizability. It is affected by random sampling. Internal validity, where I can compare study groups. This is internal validity, and it is affected by randomization. I hope the concept is clear. If the concept is clear, can I get some smileys in the chat box? Can I get some fire in the chat box if the concept is clear? If I see the fire, I'll go to the next topic. Can I see some fire in the chat box, guys? It means you understood the topic and I should go to the next slide now. Now coming to next question. Selection bias. What is selection bias? बच्चों, selection bias आपको कुछ इन्होंने टॉपिक्स कुछ डेफिनेशंस दी हैं, एंड हेयर ऑल द डेफिनेशन, ये सारी डेफिनेशंस कुछ हमारा बायस की डेफिनेशन है. ठीक है, चलो देखते हैं. नाउ फर्स्ट इज इंटरनल वैलिडिटी. बच्चे, व्हेन दीज internal validity, when these two can be comparable. Internal validity, when I can apply the result of this to the whole population. External validity. External validity is affected by random sampling. This is what I have told bache. Now selection bias. Now coming to selection bias. The bias arises because of the different. Okay, what is the answer according to you? What is the answer here according to you? Yes, the correct answer is D. Selection biases when the cases and control are not representative of general population. When they are not representative of general population. Now, but what is C? When cases may have a different recall, this C is recall bias. This is recall bias. The bias arises because of different rate of admission to hospital. A is Bergson's bias. And bias occurring when the interviewer knows the hypothesis and also knows who cases are. Interviewer's bias. Interviewer's bias. Now coming to this one. A rural area is struggling with high maternal and neonatal deaths, maybe because of substandard care during childbirth. Recognizing the urgency, the hospital administration decides to implement Lakshya initiative. What is the primary objective? What is the primary objective? So the Lakshya is to enhance the quality of care in labor rooms and maternity operation. and maternity operation. All right, guys, is it clear? Is it clear? Lakshya is related to, yes, Lakshya is related to improving quality. Improving quality. Guys, all the MCH programs, if you have the DVT workbook, all the MCH programs, they are covered in just one or two page, right? So for DVT, for MCH programs, do check DVT, right? Now, a patient. So this is another topic which almost daily, right? Guys, let us solve this, right? Let us understand it. Guys, the pre-exposure prophylaxis. What is pre-exposure prophylaxis in case of rabies? The pre-exposure prophylaxis, we give 3 doses. Yes, 1.5 page only. Thank you, bache, thank you. 1.5 page and whole MCH programs are there. Do revise. So guys, pre-exposure prophylaxis, we give 3 doses. 0, 7, 21 या 28 day पे. Now this is re-exposure prophylaxis is the one which students are usually confused. Guys, re-exposure prophylaxis, in re-exposure prophylaxis, what is re-exposure prophylaxis? The patient had a dog bite, the patient received all the post-exposure prophylaxis and now coming to you. This is re-exposure. And if a person took the pre-exposure prophylaxis and the person had a bite and the person now coming to you is also re-exposure. So re-exposure, it includes what? Previous pre-exposure prophylaxis or post-exposure prophylaxis, right? Or post-exposure prophylaxis. Now, in re-exposure prophylaxis, if it is happening less than 3 months, then you need not to do anything. Just wound wash and send the patient back home. If it is more than 3 months, right, then you need to give. If it is less than 3 months, nothing to be done. If it is more than 3 months, you need to give 2 doses. And guys, there is no criteria in Government of India guidelines, right? This is applicable. There is no such criteria, 1 year, 2 year, 5 year, nothing. Just less than 3 months or more than 3 months. If more than 3 months, we need to give 2 doses, 0 and 3rd day. And guys, one more point. If this re-exposure is a category 3 bite, even if it's a category 3 bite, do not give immunoglobulins in re-exposure. Even if it is a category 3, we need not to give immunoglobulins in re-exposure. Now, some students, they are confused that, sir, here it is a dog bite, here it was monkey bite. Will it be applicable? Yes, it will be applicable, right? Yes, it will be applicable. Now, so here the correct answer is we only need to wound clean and rabies vaccine on 0 and 3rd day, right? Now, sorted. This is rabies prophylaxis. If you ask me, this is a 5-star topic for your NEET PG FMGE exam. Arushi, in DVT, no, I didn't say this thing. No, Arushi, no. Arushi, check again. I have not given this thing in DVT. Yes, RIG given only once in lifetime. Now, bacho, next question. Again, a 5-star open vial policy. Open vial policy. Bacho, this is a 5-star topic, and again, this is a topic which confuses us, right? Open vial policy. Guys, open vial policy is the policy when the vial, once opened, can be used for 28 days. Can be used for 28 days. Now there are some vaccines which follow this and some vaccines which does not follow. So the vaccines which does not follow are BCG, measles, rubella. These are under national immunization schedule, and a recent vaccine COVID. Rest all vaccines under national immunization schedule. All vaccines under national immunization schedule, including IPV, Rota and JE killed. They follow open vial policy. Guys, I'll tell you the story why I say this. Before 2013, there was no open vial policy. Even if you are opening a TT, you have to discard other doses. In 2013, Government of India adopted open vial policy for vaccines under national immunization schedule. After that, in 2015, it was updated and some new vaccines were included. Now, rest of the vaccines, which like rabies, yellow fever, I do agree they do not follow. But the open vial policy in India is adopted by Government of India for vaccines under national immunization schedule to prevent their wastage, right? So here the best answer is use penta and discard, use penta, right? And use penta and JE, BCG should be discarded, MR should be discarded. Right? Now, vaccine strain of rubella. Guys, vaccine strain of rubella. I think there is no more confusion, right? Now, vaccine strain of rubella is, so this is for rubella. 17D strain is for yellow fever. This is for mumps. Now JE live vaccine strain SA14142 and killed vaccine strain is Indian Kolar. Guys, Genvac, many people they say the strain is Genvac. No, strain is not Genvac. This is the brand name. When this vaccine was launched, many people said SA14142 is the strain. No, the strain is Indian Kolar and the brand name is Genvac. Genvac is the brand name. Indian Kolar is the strain. Now coming to steps approach. Now I have included this question. The reason is, I'll tell you the reason. Guys, steps approach is for NCD risk factor. NCD risk factor, they might ask you, this is for NCD prevalence, NCD treatment, NCD risk factor. This is for NCD risk factor. This is for NCD risk factor. Now let us okay, I'll explain this topic. Let us listen to the story. So I want to know the NCD risk factors in my village. What I will do, I will go on step 1. What is the step 1? Step 1 is questionnaire. Step 1 is questionnaire. So in step 1, I will go, okay, listen, what happens in steps approach, I'll tell you. You listen the story and leave the topic on me. You just listen the story. So we have to assess the NCD risk factor in the village. What I will do? First of all, I will go to the I will go to the people, and I will take a questionnaire and I will ask verbal questions. I will ask verbal questions like, what is your age? What is your gender? Any family history? And what is your lifestyle? Do you smoke? Do you consume alcohol? Do you consume fruits? Do you consume junk food? How frequently? Something like that, right? We are just taking the verbal questions which are related to demography and their lifestyle, right? Then those who are found to be at high risk, then we go to the next step. What is the next step? The next step is physical. In this step, what we do? We take their measurements, their height, their weight, BMI, all these measurements we make. So here I can write measurement. Those who have high BMI, those who have high weight. Now we use the step 3. In step 3, we have biochemical. Now I will take the blood sample to know the liver function test, lipid profile, and HbA1c, and all of these tests. Now guys, anywhere in this story, am I doing the treatment? No. So therapeutics are not included. Physical, yes, I am taking. In step 2. Psychological and behavior is assessed in step 1 itself, right? That is why therapeutic is the single best answer here. No confusion, no controversy. Guys, I tell you, PSM is a very beautiful subject and with least controversies. Why I say it has least controversies? If you are studying any pharmacological drug, right guys, if you are studying physiology, pharmacology, anything, in PSM we have to just follow the guidelines. If we are not following guidelines, we will create controversies, we will be in controversies, right? Now coming to next. So one student is saying in DVT, bache, what I told in DVT about Pradhan Mantri Yojana, Pradhan Mantri Matru Vandana Yojana, whatever I told in DVT, it is updated now. Right? It is updated now. Now, many students said, sir, please once explain the demographic cycle. It is confusing. So I am here explaining you demographic cycle, and we will look for the question later. Guys, this is birth rate. This is death rate. In stage 1, birth rate is high. And death rate is also high. and death rate is also high. In stage 2, the birth rate remains high, but death rate starts declining. The death rate starts declining. The death rate starts declining. In stage 3, the birth rate also declines and the death rate further declines. The death rate further declines. In stage 4, the birth rate is low, the death rate is low, but there is a stability. In stage 5, the death rate goes now. So this is the demographic cycle. This is the demographic cycle. Now बच्चों, this here we have high birth rate, high death rate, but the population is stable. Here we have low birth rate, low death rate, population is stable. And in stage 2 and 3, the population, the gap is more, the population will expand. But here it will decline because more people are dying than taking birth. So here the correct answer is declining stage. Here the correct answer is declining stage. Now, बच्चों, DVT is the most updated. There are minor updates. If there are minor updates, many students are asking in the chat box about the updates. Guys, I have PSM Pro 3.0, the recent addition. The recent addition is there. It is there, right? One change which is there after DVT, and I have included here, right? Everything at one place. DVT is the gold standard. Do not panic. Only one change is there. Rest DVT is totally updated, right? Now, next question. This question, many students were confused. Okay, let us leave the question. Now tell me, let us leave the question. Let us talk about the concept. What is maternal mortality? What is maternal mortality? Any death of a woman during pregnancy or during childbirth, during pregnancy, during childbirth, after delivery, up to 6 weeks. This is maternal mortality. Now bachcho, I have one question. If any death of women during abortion, so the guidelines say irrespective of site and duration. So if any woman is dying because of ectopic pregnancy, this is maternal mortality. If any woman is dying because of abortion, this is maternal mortality. Now the exception here is exception is accidents. Accidents are not. Any pregnant women dying because of accident is not a maternal mortality. Any pregnant women dying because of abortion, it is. Any pregnant women dying because of site, ectopic pregnancy, it is maternal mortality. Now, so let us see the question. Dr. Rohit Das, you go to Telegram, it is there on my Telegram group. It is there in my Telegram group. You go to Telegram group, you find probe, you will get it. It is just a few pages PDF. That's it. Nothing like that. Rest your DVT notes are gold standard. Now बच्चों, what is there? Total population 2 lakh, live birth 4,000. Now 2 deaths because of ectopic pregnancy. Yes, this is maternal mortality. 2 deaths because of puerperal sepsis. Yes. 2 deaths because of abortion, PPH. Yes. But these deaths because of electrocution, they are not included. So how many maternal deaths? 2 plus 2 plus 2 plus 4 divided by live birth, number of live birth. How many live births are given? 4,000 into 1 lakh into 1 lakh. Now, so here the correct answer is 250. Bache, Nitya is asking, sir, what about 7 weeks? Guys, WHO said that if any death after 6 weeks, it is denoted as late maternal death, right? Late maternal death. Now, coming to this question, FSSAI is a regulatory body which is responsible for ensuring the food safety and hygiene standards in India. So FSSAI comes under Ministry of Health and Family Welfare. Ministry of Health and Family Welfare. So FSSAI comes under Ministry of Family Health and Welfare. And this egg mark comes under Ministry of Agriculture and Farmers. Ministry of Agriculture and Farmers. Sir, what is the purpose of giving population? Bache, just to confuse you, hai na? Just to confuse you. There is no significance here. This is the case history of that question. All right. So we are done with our mini test series, and now this one thing which students are confused, and I want to discuss this. Diphtheria contact management. Guys, diphtheria, if any child comes in contact with a diphtheria case, what you will do? Number 1 point is you quarantine. Second point, you take the swab. You take the throat swab. You take the nasal swab, right? You take the swab. Now, you take the swab. Third thing, give antibiotic irrespective of immunization status. Irrespective of immunization status, we need to give the antibiotic. Which antibiotic? Yes, which antibiotic? So the Government of India guideline says it can be penicillin, erythromycin. Penicillin, or better I should write this, not both, any one of them, right? Irrespective of vaccination status, right? Now coming to chicken pox. Guys, for chicken pox, if there is a high risk group, who are the high risk group for chicken pox? No, Nitya, not at all. There is no confusion, bache. No confusion at all. Why I am saying Government of India guidelines, WHO, Nelson, Harrison and OP-Ghai. These resources, they say irrespective of vaccination status, antibiotic should be given to the diphtheria contact. right? MMR maternal mortality is 6 weeks, बच्चे 6 weeks, 42 days. Now, who are high risk group? Let us discuss this one. So, chicken pox, who are high risk? Any immunocompromised or pregnant or infant. These three are Arushi, teachers, pregnant, immunocompromised. Teachers are not high risk for this one. Alright, so what we need to give? Varicella zoster immunoglobulin. What is the dose? 12.5 international unit per kg. The chicken pox vaccine, Oka strain and contraindicated in pregnant and immunocompromised, right? Now, what about malaria? Guys, for malaria we have short-term prophylaxis, long-term. Guys, one point I want to tell you, like malaria prophylaxis is not given to everyone. Those who are going to endemic area, only that people, only those person they can take. For rest of the people we advise for malaria use nets, right? Use net. Very good, Dr. Vibhor Jain. Varicella zoster immunoglobulin within 72 hours. Within 72 hours. Now for short term, doxy. For long term, mefloquine. H1N1 influenza, H1N1, oseltamivir, OD 75 mg for 5 days. This is for prophylaxis. If you have a case of H1N1, then oseltamivir 75 mg for 5 days BD. Then BD. OD is given for prophylaxis. Same, everything same. BD is given for treatment. It is treatment. Meningococcal ceftriaxone. Ceftriaxone. Chloroquine prophylaxis, according to National Vector-Borne Disease Control Program, chloroquine prophylaxis is not advised. Any guess why? Bachcho, any guess why we are not giving chloroquine prophylaxis? I do agree, WHO and CDC recommend that chloroquine can be given for prophylaxis, but National Vector-Borne Disease Control Program does not recommend. Any guess why? In the chat box, be it your guess, right? We are not here for viva, we are not here for your final exam. Just make the guess. गलत ही होगा ना, maximum गलत होगा, है ना? चलो, leprosy rifampicin. Very good बच्चे, विनीत वधवा. Very good बच्चे, resistance. Very good Dr. Sahil. Very good Dr. Vineet. Resistance. Because chloroquine is the main treatment for Plasmodium vivax. If I start giving, then there will be problem, right? Now, leprosy के लिए rifampicin single dose. Single dose. Now, guys, this was one topic which students, they are very much confused. So I wanted to compile this. I thank you all for your patience. I thank you all for your patience. I wish you all a very good luck. So thank you all for listening patiently. Thank you all for giving these mini test series. Keep giving these series, right? Keep studying. All right, sir, should we do CBNAT? Is micro confirmed DB or not? Yes or no? Please reply. Bache, CBNAT, okay, listen. Dr. Ekadashi, listen. CBNAT is done for treatment initiation. Even if you are confirming the TB, because in the remote areas where CBNAT is not there, we have to make diagnosis. So sputum and chest X-ray are used. But for starting treatment, CBNAT is used. There is no confusion in that, because nowadays we are giving treatment on the basis of resistance or not. Thank you, bachcho. Yes, DVT is a very good revision tool. DVT is a very good revision tool. It is very good revision tool. Right? Thank you so much. Here I sign off. Right? Thank you so much. Keep studying. If still you have any doubt, feel free to message me. Feel free. And those who are asking about probe, it is just a small PDF. You can get your PSM Pro PDF from here. I will also upload on DAMS official Telegram group.